Hi, everyone, and welcome to our webinar today on the somatic and paired testing and care delivery approaches. We're very excited to have with us Leigha Senter. Leigha is an associate professor and a licensed and certified genetic counselor at The Ohio State University Comprehensive Cancer Center. She received her bachelor's degree in molecular genetics at The Ohio State University and her master's degree in genetic counseling at the University of Pittsburgh. Ms. Senter's research interests are in cancer genetics. She has a particular interest in hereditary gynecologic cancers and cascade genetic testing in families with hereditary cancer syndromes. She has co-authored several publications in the area of genetic counseling for hereditary cancer, with a focus on BRCA-related predispositions for breast and ovarian cancers. Thank you all for joining, and thanks very much to our speaker, Leigha. I'll hand it over to you.
Great. Thank you so much for inviting me. I will start by saying I'm very happy to be speaking to this group, many of whom I know personally, and those that I don't, I know of your work. And I will also start by saying I'm at the tail end of a cold here, so if you see me sort of tap out and get water occasionally, my voice leaves without any sort of warning these days. But I'm very happy to be talking to you for the next several minutes about the role of the genetic counselor and how we can incorporate genetic counseling when we are adding somatic testing to the mix. So what I hope to do is just explore the different approaches to testing in patients who might benefit from both types of testing. And we'll review the current opinions about counseling in the context, particularly with the focus on somatic testing. I think we're all pretty well aware of how counseling works in the germline space. And then hopefully consider the facilitators and barriers of counseling within this idea of pair testing. But what we will not do, so our negative objective is review the exact targeted therapies and sort of disease-specific applications of somatic testing. That would be for a completely different day and hopefully a different speaker. So why am I speaking to you about this? I have talked about this before, but largely because my clinical effort is focused in gynecologic oncology. So I am embedded in that clinic where I support 8 different physicians who work in GYN oncology. Many of them may look familiar to you, and it's an interesting place to be, but I mentioned that there are 8 of them because I'm only in clinic 2 days a week, and they are in clinic collectively 2 simultaneous clinics 5 days a week. So as the only genetic counselor for quite some time, we were able to sort of establish this protocol for germline and somatic testing, even with little genetic counseling effort, which I'll sort of refer back to at the end of the talk. But germline genetic testing has, of course, for years been recommended universally for women with ovarian cancer. And the importance of that got underlined when the FDA approved PARP inhibitors in ovarian cancer early on. Somatic testing then became one of the FDA approved indications. And so it became very much part of our collective care of the ovarian cancer patient population. And in our institution, I sort of oversee both kinds of testing. So a lot of what I will be talking to you about today is based on, of course, what's in the literature, but also on our own experience too. So it goes without saying, but I will say it anyway, that we know for sure that germline testing and tumor genomic testing should be offered to many patients with cancer, and that applicable application or population continues to grow. And we know also, and the NCCN even has guidelines that support this, that if tumor testing reveals pathogenic variants in specific genes that are relevant when mutated in the germline testing should be done in follow-up or as a reflex. There are institutional differences. So some institutions have in place a process for universal testing for their patients. Many don't. We don't at Ohio State. But what we also know is that there's no consensus on where the genetic counselor or if a genetic counselor should be involved when it comes to incorporating somatic testing in the care of these patients. So there are obviously a lot of approaches, and these are just the very sort of bare bones ways that an institution may approach the testing process for patients who might benefit from both types of testing. So in some places, they start with the tumor test. So start with somatic. And if a pathogenic variant is identified in a germline relevant gene, or if there's a high pretest probability, for instance, of a large rearrangement or deletion that wouldn't be picked up through somatic testing, then they might move on to germline testing. The opposite can also happen. So some places start with germline testing, and then if they receive an uninformative result, or they just need to include additional genes that might be covered in a somatic test that aren't relevant in the germline, they proceed with somatic testing, or you can take this simultaneous or paired approach. And there are certainly, if you were to get very granular, differences and nuance within each of these, but these are sort of the broad categories. And how does one decide how you might go about this? And the truth is that it's going to be different probably for different diseases specifically. So I often compare lung cancer to ovarian cancer, and the need for various tests is going to be very different. So providers need to consider what companion diagnostics have the highest yield in this particular clinical scenario, and how much time do you have? Are you in a very acute setting where the prognosis is very poor and you just need all of the information that you can get at first step? Or do you have the luxury of being able to do things in a stepwise fashion? Oftentimes you need to consider institutional resources. Is your testing done in-house? Do you have staff to handle the logistics? So the collection of multiple samples and multiple insurance authorizations and tracking of test results, and who's going to own that? Cost considerations, of course, to the patient, your healthcare institution, healthcare system at large, what works best in your payer mix, and what specimens do you have available? A lot of the tumor testing is done on archived paraffin tissue, but you don't always have that available, of course. And so for some malignancies that are primarily a clinical diagnosis where you don't have a specimen available, that might push you in one direction or another when you're deciding which test to do first, or if at all. So one of the papers that I think was circulated ahead of this presentation was actually a commentary in the JNCI, and much of what was included there is probably logical and makes sense to this group, but I thought that this particular graphic was a nice way to break down in its simplest form sort of the pros and cons of either starting with germline tumor tissue or doing it in a paired fashion. And again, in any special disease setting, the pros and cons are going to weigh differently, I would imagine. But I find this graphic to be interesting. I probably will use it when speaking to people in the community that have different levels of resources, because I think that is another big part of how you might decide how to approach this in any given setting. But I thought it was interesting. I don't know if you can appreciate it on your slide, but under the green graphic for paired and normal, one of the cons was actually the increased costs and resources, particularly related to genetic consents in counseling. And I might have a different view about that, but I'll sort of touch on that as we sort of go through. But they're really talking about people resources and the time that it takes to sort of consent to two kinds of testing at one time. So this is a table that I really don't expect you to be able to appreciate the detail or the words actually on this page, but I'm sure it's not new to anybody in the audience, but it's come from the 2015 ASCO policy statement on genetic counseling with regard to germline testing, but then they've since updated it over time. So I think we've established pretty good general consensus about what should be included in pre-test education or genetic counseling when we are doing germline testing. And that's what you see in the column to the left. So those are various content areas that the experts have achieved consensus around. These are the things that should be discussed. And then when panel testing became available, that middle column added to that already long list. But for somatic mutation profiling, which is the far right column, this is where there's a little more lack of consensus and sort of what genetic counseling would actually entail in that setting. But there's an attempt. And so there are some items outlined there that were agreed upon. Just to kind of zoom in, and normally I would never read a slide directly, but I'm going to here. So this again is from that same ASCO policy statement. So ASCO supports the communication to patients of medically relevant incidental germline findings from somatic mutation profiling conducted in the clinical setting. And then they go on to say that oncology providers should communicate the potential for incidental and secondary germline information to patients before conducting somatic mutation profiling and should review the potential benefits, limitations, and risks before testing. Providers should carefully ascertain patient preferences regarding the receipt of germline information and allow patients to decline receipt of germline information. So we're going to zoom in on a few words in particular. So just taken from those couple of statements, they obviously say that this communication should be before somatic mutation profiling, that the review of the benefits, limitations, and risks should happen before testing, and that providers should carefully ascertain patient preferences. And I don't know about you, but a lot of those things sound very similar to the things that we would discuss in genetic counseling prior to germline testing. I think it is important to note also that the authors of this policy statement, all come from a hereditary cancer background of different disciplines. And so their expertise lent itself to very much align with what genetic counseling practice has traditionally been over time. And here's another policy with a slightly different slant. Again, this is an ASCO guideline, but this one is specific to epithelial ovarian cancer for germline and somatic testing. So they have a lot of the same components, but they actually talk about the fact that non-genetic providers should establish working relationships with genetics professionals. And ideally, results of genomic testing should be delivered in conjunction with a genetic counselor to communicate the complexities and far-reaching implications of results. They go on to say that while discussing considerations of genetic testing, such as potential uncertainty with test results, limitations, implications for hereditary cancer risk in family members, and insurance discriminations, that the clinicians should acknowledge the patients and family members' feelings of worry, anxiety, guilt, fear, etc. Again, very much mirroring what a genetic counselor would do, or just genetic counseling in general is sort of aimed at achieving in this setting. But these policies exist, and how realistic is it that this is actually happening in an oncology office where they're doing somatic mutation profiling? This is unpublished data that we did and sort of ramp up to an R21 that I'll talk about at the end of this call. But we just wanted to see if the oncologists in our institution were covering any of this. And this always drives me crazy, but the vertical axis doesn't go up to 100%. So I don't want that to be misleading anyone. But we asked questions of our own oncology group, what percent of patients that you treat undergo this kind of testing? And that was kind of across the board. But then we asked, with what proportion of patients do you discuss the limitations? With what proportion of patients do you discuss incidental findings? And for limitations, it was a little over half. With the potential for incidental findings, less than 20% discussed it with all patients for whom they order this test. And more than half of providers said that they didn't have enough time to have these discussions. So nearly all providers discuss the potential benefits of testing with all of their patients. Little more than half, like I mentioned, counsel patients on the limitations, and less than 20% discuss the potential incidental findings with all patients. So what are the patients telling us? There have been a couple of papers published about this, but we know that sometimes patients are reluctant to do testing. And there are various reasons for this, as there are with all things, but sometimes this is attributed to the possibility of incidental findings. Also, information overload. Sometimes tumor testing is appropriate either at the time of a new diagnosis or at the time of a recurrence. And we all know, the weight of that information that it puts on a patient. There's also some reluctance attached to the lack of clear benefit. So they're not sure that it's really going to make a difference for them. But in a separate study that is published, we asked patients, 100 metastatic breast cancer patients, about their feelings about this. And one interesting thing that we found, which I don't think that we anticipated, were that patients whose treatment did not change based on tumor genomic testing had a significant decrease in confidence of their treatment success. So the patients were overly optimistic. Almost half believed that that testing would guide their therapy, when less than 12% it actually did. And I'm actually going to back up a slide and just remind everybody that in this same group, so these would have been the doctors for the patients that we surveyed, far more of them discussed the benefits of testing than the limitations of testing. And so, this might have something to do with the need for consistent messaging. So, our study showed that patients who undergo this kind of testing and their therapy doesn't change lose confidence in their treatment. And we know that that's not a trivial detail, because it's established that this provider-patient relationship and sort of working as a team together really can improve adherence to their therapy because they feel like it's going to work. It improves caregiver coping, and cancer outcomes are shown in some studies. So these data tell us that we need to manage expectations. And will genetic counseling help? Can involving a genetic counselor or going through the process of genetic counseling help set those expectations in a realistic way? Or maybe a standard message will help. And I'll get to a little bit about what we're going to try to assess about that. So whenever we're talking about new test offerings and the communication that comes along with, we think about shared decision-making too. And this particular paper, I always find fascinating because it was such a large sample size, but they assessed in a surgical decision-making setting whether or not participants perceived that they were engaged in the decision. So they were actually part of the decision-making process. And the good news was that the overwhelming majority said yes. But when you zero in on those that didn't, the 11% that reported poor shared making of the decision, there was an overrepresentation of non-white race, lower education level, lower SES, being single, and those that were under or uninsured. And while this was a minority of the group overall, we have to be really careful when we're talking about messaging and making sure that we're being accessible to all of the patients, especially those that have been historically marginalized. Because of course, a lack of shared decision-making also can be associated with poor health outcomes. But in this particular setting, when we're talking about somatic testing for variants in genes that might dictate a particular cancer therapy, the question becomes, is tumor genomic testing really a shared decision? So one that a patient can opt out of, and what happens if they decide against it? And of course, this does happen in real life, but I think we can also appreciate the fact that sometimes, as the oncology providers, this is not presented so much as an option, it's presented as a test that's happening. So I'm going to talk a little bit about our approach in gynecologic oncology at Ohio State, and I will disclaim just that this is not a proven best practice by any means. It's just sort of how we're approaching this. So it's our goal that all patients diagnosed with ovarian cancer are referred for genetic counseling. And the way that works is that they are referred as close to the time of diagnosis as possible. And it's a standing item on their tumor board assessment. So when they're reviewing, what therapies to consider, they review whether or not the person needs to see us in genetics. We also have a safety net for this referral process where we're doing a monthly report of all new ovarian cancer cases, post-op and outpatient visits. And that just allows us to catch any patients who might slip through the cracks. And it just comes from our cancer program analytics and doesn't actually take that long to do. Our goal is to order germline and somatic testing concurrently for all patients with ovarian cancer, and I oversee that when they come and see me for genetic counseling. The exceptions, there are a few, but the main one is when a patient, if they're referred to see me and they're in the process of neoadjuvant chemo, and there's no pathological specimen available, oftentimes I will do the germline testing with a plan for the nurse practitioner to order somatic testing at the time of their debulking surgery or post-op visit. When I do result disclosure, which at Ohio State happens over the phone, I document both results if I'm the one who sort of ordered those or facilitated the process. So in OneNote, I will document the germline result and the somatic result. We upload the PDFs to the EMR and we highlight it in the problem list in Epic. But you might be thinking, wait a second, genetic counselors don't need somatic testing for risk assessment. And this is true. It's very true. But at our institution, we have an official collaborative agreement with the physician, and we sat down and basically came up with a decision tree. So I don't think of ordering the somatic testing as my, I didn't decide this, what test that they need in order for their therapeutic decisions to be possible. But I work in collaborations with the physicians that I support, where we know that ovarian cancer patients with certain histologic features, we prioritize this test, and a second choice would be this test. And it just allows us to sort of streamline things. From an actual counseling perspective, I can tell you that it's very easy to talk about tumor testing if you're already talking about germline testing. I think there's a lot of overlap. It allows us to check the boxes from those ASCO recommendations, really. And I'm already spending the time sort of outlining benefits and limitations and, potential for hereditary risk. So incorporating tumor genetic testing into my practice was not a big leap. Whereas adding this laundry list of things for a single test for the oncology practice, when they've already got a dozen other things to cover in a given visit, would have been a big practice change. So I think for us, it was, how can we do this and be the least disruptive? And so this may be a little cheesy, but I think sometimes when I'm out talking about this, people will be like, well, how can you talk about it and not talk about the actual therapy that's going to happen or not happen based on their genetic test result? And so here's what you might overhear me saying. So I might call a patient with their germline result, and I'll say, we also have your tumor test result, and we're going to make sure Dr. O'Malley knows that it's back so that he can discuss it with you at your next visit. Easy as that. Or I might say, while your blood test result didn't reveal variants in BRCA1 or 2, your tumor tissue did. And in that situation, we need to make sure that the patient knows that it does not impact their family members, because that's another point of confusion. They'll think that they have their negative test result, that they don't need to make family members aware, and then they get this somatic result separately, which seems to contradict the result that they already got. And so if we're talking about it in the same vein, essentially, I think it does aid in, I hope it aids in, patient understanding about their results as a whole. And so why does this work for us? Ovarian cancer is a little unique in that most patients, 80% or so, generally should have both kinds of tests, germline and somatic testing. And what we've learned from experience is that simple is better. So having one discussion about the bulk of the testing can cover it. It allows us to miss fewer opportunities. And when a point person sort of oversees and owns the process, it just makes it clearer. So for everybody involved, the patients, the providers, the staff, it has really been beneficial. I'm just going to sort of gloss over this, but when thinking about practice changes, what you see on the left-hand side of the slide is our old traditional way of doing things. When we had patients that we required them to come see us in genetics at a separate location with a separate visit, and they had all kinds of paperwork to fill out. The little clocks are areas where there can be a delay from the time of referral to being seen. And the stop signs are areas where patients can drop out of the process altogether and are never seen. And in the old way, there were multiple places for both of those adverse events. But when the genetic counselors actually went to the oncology clinic, and I'll actually counsel people while they receive chemo sometimes, we not only eliminated all of the potential for delay, but we really reduced the times that a person either opts out or just doesn't follow through with a complicated process. So for us, while this pertained to germline testing, it really did show us that we need to sort of simplify things from the patient's end. So you might be wondering, okay, all of these cancer patients will eventually probably need tumor genomic testing, and how realistic is it that a genetic counselor be involved? Is it feasible to include a genetic counselor in the process for every single patient? Of course not. But it's important to kind of think about how genetic counselors are being used at various institutions. So are you still working in a very traditional model that restricts the scheduling, for instance, or where a genetic counselor can see patients? Thinking about where genetic counselors can operate at the very top of their scope and doing less of the sort of administrative clerical details. Are you still having very long appointments? I can say even with somatic testing, I very rarely go over 30 or 40 minutes. I know that's stylistic, but and are you still having unnecessary paperwork, et cetera, et cetera? And the graph here that you see is the growth of the genetic counseling workforce. So that's not to suggest that this is feasible in all places to have a genetic counselor involved, but I think there are more genetic counselors available and the workforce continues to grow sort of exponentially. And so it might be feasible to incorporate genetic counseling in more places than they currently are when we're talking about tumor testing. Another factor that can facilitate that access is, of course, state licensure, which then sort of sets up the stage for these collaborative agreements and ability to order germline testing at least. Setting up QA processes, I think, also really helps. So I had mentioned early on that we sort of do this double check for ovarian cancer patients, but that's data that we already have to collect with the Commission on Cancer and our accreditation bodies. So it's just pulling it in a different cycle and actually looking at the data instead of annually every month, just to make sure that the patients are getting access to the counseling and testing. I made note here that genetic counseling is offered by commercial labs more and more often these days, not because I think it should be used in place of clinical genetic counseling, but I think when we think about access to care in places for people who don't have access to on-site genetic counselors or even in their state, it wouldn't be used so much for the tumor genetic counseling process, but it could, I think, be used to augment and increase access from a germline perspective. And so just another quick word about logistics. When I think of paired testing, I think of something that's truly paired. So we are ordering a test, hopefully one test from one laboratory, and it's giving us somatic information and germline information. For those of us who work in places where we don't have this offering as part of our institutional infrastructure, that's very hard to come by. You know, a couple of laboratories have partnered in a corporate way, but oftentimes from a clinical care perspective, it doesn't really make that big of a difference because it's still separate billing, separate paperwork, and all of those things that sort of give us headaches on a day-to-day basis. And then there are, of course, offerings where they collect a somatic sample and use a normal specimen for sort of adjudication of variants. In that situation, they often report the germline findings as incidental and recommend that you confirm that in a germline laboratory anyhow. So again, we've not reached a point where there are really simple options for patients who need both kinds of testing just yet. So I'm going to speak just a little bit about a project that we're just getting off the ground. And this was largely anchored in our understanding that even in our own institution, people are not really checking the boxes that at least the experts are saying we should be checking in sort of pre-genomic tumor testing education. And also this idea that we're beginning to understand that we need to have a consistent message and we need to take out the subjective sort of, we're really hopeful about this because it leads to a letdown after the test results come back. And so we recently had funded an R21, and this is the title here. It was just funded a couple of months ago, so we're still in the very early work. But our hope is to develop a video message that can be provided to a patient after this tumor test is recommended by their oncologist to sort of just set the stage and give them the information that at least at baseline we all think should probably be included. We know what's out there by these ASCO policy statements and others, but we also felt that it was important to see what actually mattered the most to patients. So this is not based on formal transcript evaluation yet. I sort of just am giving you my general gestalt because these focus groups actually just happened. But, you know, we reached out to metastatic breast cancer patients. Some had had testing and some had not, and conducted focus groups about, you know, what are their opinions about the potential for incidental findings? Did that come up at all? How do they feel about it? And various other things. But two takeaways that I sort of fell upon were that the provider discussion is the most important. You know, maybe not surprisingly, these patients rely heavily and trust their provider explicitly. And so any video message or sort of supportive materials that we develop will not take the place of that discussion and relationship for sure. And we wouldn't try to. But there seem to be very divergent views about this incidental germline information when it came to giving information about themselves. So they again have metastatic cancer versus that it might impact their family members. So at first, everybody said, oh, yes, I would definitely want to know. And it was pretty uniform across the two groups. But when we talked about the fact that that could impact family members, there was a lot more hesitation. And so I think that that's something for us to be really thoughtful about, but also underscores the idea that genetic counseling, as we traditionally think of it, those are the kinds of things that we're used to talking about. And so making a case for it in the context of somatic tumor testing is not that hard to do. And then the lung cancer groups, which I'm sure will have differing opinions, are currently underway. So just to wrap up, I think that it makes good sense. You know, it may not be completely feasible all of the time, but to include genetic counseling, plus or minus a genetic counselor in the process, particularly in settings where the likelihood of finding a germline meaningful result is reasonable. Adding tumor test discussion to the germline discussion is not difficult and does not take a lot of time. When we engage the patients in the decisions about testing, I think as, you know, just sort of a collective group, you know, a lot of us are coming from a germline space where testing often is exactly optional. You know, people opt out frequently. And in tumor testing, I think the motivation is a little different, and the decision about whether a patient truly feels like they can opt out or not is probably quite a bit different. And I think that what is recommended in the literature and what is actually happening in clinical practice is quite different. So anything that we can do to sort of make those two things meet in the middle, and it could be that expectations are maybe a little too high, but I think that that would ultimately be a good thing. So I will stop there before my voice totally tanks, and I'm happy to take questions.